Welcome, everybody, to yet another episode. This is episode 6 for Rising Stars in Ophthalmology. I think we're going to be talking about something extremely important to all of us as anterior segment surgeons, maintaining a refractive mindset when performing cornea or cataract surgeries. But before we get into the topic itself, let me explain how this whole thing works. Each episode usually stars one rising star, and we surround them with 3 celebrity panels. And these are people who are, cherished around the world. And we love them because they mentor us in terms of what we do and what we should be doing, what the field should be doing in the field of ophthalmology. And we as moderators honestly have nothing much to do. This is a very interactive series, so any audience member that's watching can always throw out questions in the YouTube channel called Rising Eye Stars in the website, and the YouTube channel called Rising Stars in Ophthalmology. We're live on risingeyestars.com and on our YouTube channel, so please watch out for them. The reruns can definitely be watched on the website, so definitely go back. I know this is a very global event and the timings might not suit everybody at any time. Keeping that in mind, we also have social media, Facebook, Twitter, LinkedIn, and Instagram. So we do release a lot of educational tips and snippets across for all the episodes. I'd like to really personally thank every one of you for tuning in, and thank the sponsors, because without which this was not possible. To do the honors for the sponsors, as well as the Rising Star and the Celebrity Panel, I'd like to now call upon my co-moderator, Jennifer Lowe, who's going to be talking to us a little bit more.
Hi, thank you so much, Ashwin. As always, it's an honor and pleasure to be able to co-host this, wonderful event with you. As you mentioned, I do want to take a moment to thank all of our season sponsors. And we do have a slide showcasing all of our sponsors who we really appreciate. And that's including Allergan, Alcon, Vices Therapeutics, Dompe, Avellino, Young MD Connect, Sun Ophthalmics, and Tarsus. Once again, thank you for your support. And we do have a special sponsor for tonight's episode, which is Dompe. And to lead a quick discussion, we have Jill Paik from Dompe.
Thank you so much, Dr. Lowe, for having me on tonight. Just pull up my little presentation for you all. Okay, thanks. So hello to all of the established and rising stars within ophthalmology. My name is Jill Paik, and I'm the Director of Field Marketing for the West region here at Dompe. For those of you that are rising stars, as you're familiarizing yourself with industry, you may recognize that there are very few family-owned companies in our space. So tonight I'm excited to share a little bit of an overview of a very special family-owned company that really entered the ophthalmic space just 4 years ago. So Dompe is not a new company. It's actually been innovating for over 130 years with a broad portfolio ranging from primary care to innovations in biotech. As you can see here, Dompe has been embraced by many generations of Dompe family. Our current leaders, Sergio and Natalie Dompe, are a father-daughter duo, acting as co-CEOs. The family has embraced the challenge of science with passion, and being privately held, they have been able to make decisions decisively and truly focus on long-term R&D strategies to bring solutions to unmet needs. When our current CEO, Sergio Dompe, took the helm of the company in the 1970s and 80s, he really transitioned the company from primary care to biotech. And that has really become the heart and core of our strategy and the future of Dompe. In 1993, the company built and now runs its own plant, a biotech plant for recombinant proteins used in the treatment of rare diseases. And following the development of that plant, Dompe developed, produced, and commercialized one of the most important biotech innovations for ophthalmology based on nerve growth factor, the protein discovered by Nobel Prize laureates Rita Levi-Montalcini and Stanley Cohen. In 2018, the US FDA granted Oxervate a breakthrough therapy designation, enabling Dompe to enter the US market with an FDA approval in 2018. So I talked to you a little bit about the history of Dompe and where we are currently. And now I'd like to talk to you a little bit about our future. So Dompe's focus is to target high unmet needs within the anterior segment. We are invested in the growth of our neurotrophins platform, as you can see here. We've taken the knowledge of the mechanism of nerve growth factor and really furthered our research platform specifically within the anterior segment, with several ongoing clinical trials in neurotrophic keratitis, Sjogren's dry eye, and neuropathic corneal pain. So I'd like to toast all of your futures in ophthalmology. We are so excited to grow with you as we continue to innovate in eye care for our patients. So thank you on behalf of my Dompe family, and have a great program tonight. Thank you.
Oh, thank you so much, Jill. We really appreciate that's a really amazing history. I also love the family photos at the end. That's very nice. So again, thank you for sponsoring tonight's episode. And as always, we appreciate Dompe's amazing support, and we love, always working with you and your team.
Thank you.
Of course. So now, without further ado, I'm going to attempt to share my screen in order to introduce our amazing panel and rising star tonight. So let me get started here. Okay, so first I did want to introduce, before we get to the rising star, I wanted to introduce his panelists, or celebrity panelists as we call them. And first up, we have Dr. Renato Ambrosio, who he hails from Brazil, and he did medical school in the Sousa Marques School of Medicine, residency in the Instituto de Ophthalmologia Tadeu Svintal, hope I'm pronouncing that correctly, fellowship at University of Washington, and he's currently a professor of ophthalmology at the Federal University of Rio de Janeiro. He's president of the Refractive Surgery Alliance and president of the International Society of Refractive Surgery. And a fun fact, we always have to have a fun fact about our speakers. Sorry, 1 second, just having a little issue here. Okay, wait, sorry, 1 second. Video participants. Okay, so sorry guys, just can't move my little thing. There we go, sorry. Okay, so fun fact, he's from Brazil, but he's not a good soccer player. He does play piano, and he's a Stoic philosophy practitioner, and he has a pedigree in Brazilian Jiu-Jitsu. So thank you very much, Dr. Ambrosio, for your expertise on tonight's episode. We really, really appreciate all your efforts and your pearls of wisdom tonight. Okay, next up. Oh yeah, thank you. Next up, we have Dr. Guillermo Amescua. He did medical school in the Monterrey Institute of Technology in Monterrey, Mexico, residency at the University of Pittsburgh. He also did 2 fellowships in cornea and refractive surgery, and also in cornea, ocular surface, and uveitis at Bascom Palmer. He's currently associate professor of clinical ophthalmology and medical director of the Ocular Surface Service and medical director of the Ocular Microbiology Laboratory at Bascom Palmer Eye Institute. And some fun facts about him are, here we go. He loves to run and play tennis, and he probably is best known for, and he's very famous for his Instagram page called Cornea Poppy. So if you haven't checked out his Instagram page, definitely follow him because there's always lots of interesting pearls and cases to see there. I follow you myself. So, okay. And I don't know if Dr. Julie Schallhorn has been able to log in yet. I do believe she's still doing surgery out in the West Coast. So they are a few hours behind us on the East Coast, but I think she'll be joining us as soon as she can. Dr. Schallhorn did college at UCLA in chemical engineering, medical school at the University of Southern California, residency at UCSF, and fellowship. She also did 2 fellowships, uveitis at the Proctor Foundation and cornea and refractive surgery at Casey Eye Institute. She's currently associate professor of clinical ophthalmology and the Rose B. Williams Endowed Chair in Corneal Research at the University of California in San Francisco. And her fun facts include she raised over $300,000 for the Cystic Fibrosis Foundation. I'm sure she has an interesting story about that, so we'll have to find out later. Okay, so now on to our rising star who makes this all possible. I'd like to introduce Dr. Joaquin de Rojas. He did college at Boston College, medical school at University of Pennsylvania, residency at Columbia, fellowship at Wilmer, and he currently is the cataract, refractive, and corneal surgeon at Center for Sight in Florida, and he's the director of the Cornea and Ocular Surface Disease Department. So for him, also a fun fact before we launch into his PowerPoint, he's always been passionate about restoring and enhancing human function. And he actually did his first year of neurosurgery residency before seeing the light and turning to ophthalmology. So I'm sure you also have amazing stories to tell us about neurosurgery residency, Dr. De Rojas. And maybe we'll have time at the end to chit chat about that. But glad you came over to the other side. So now I'm going to launch into your photos that you shared with us, so we can tell our audience, the personal side of your story. If you'd like to kind of launch into that, and I can advance the slides when you tell me to. So.
Sure. Well, first of all, thank you guys for having me. I think this is such a great thing you guys do, to help young doctors like me just get out there and kind of tell our story and things we've learned along the way and more to come. So that was kind of a good segue because I saw myself at the end of my first year of neurosurgery residency, and I thought, I made a mistake. This isn't for me. I was able to rotate in ophthalmology actually as a resident, and I remembered my experiences in medical school. So here I am a year later, my first year of ophthalmology residency, and I'm with three young ladies here who became my really good friends, and we're next to Jack Chaffee, who's the chairman at Columbia University Medical Center for Ophthalmology. And we used to have these Christmas parties, a lot of fun. And he was, Dr. Chaffee was an awesome mentor. He brought me in, so I'm going to be thankful to him forever. And we'd even have these retreats. So on the right, we had these like slumber party. We had like a slumber party retreat. It was our idea. Come in like pajamas, but basically every year we have this retreat with the residency, and I think they're still doing this. And just to discuss what's worked, what hasn't worked, what's good and bad. And that's where, we really became close friends. And one of these ladies became more than friends. You can go to the next slide.
Well, I do have to ask quickly, which is harder, neurosurgery residency or ophthalmology residency? I have to know.
Well, different, but ophthalmology residency. Let's say that.
Well, not to interrupt your story, but you may have seen this beautiful lady in these pictures before already in our prior season. And I'll let Dr. De Rojas introduce her a little more in depth.
We were really good friends for a year. And then we became lovers. So this down here is a photo when we got engaged. We took a boat to the Brooklyn Bridge. This is actually the first year of our anniversary of dating, and we got engaged. And then on the right here, the photo of us at our wedding. This was at the end of residency, and this is around the time we had matched. So what's interesting about this is, not only were we co-residents, best friends, now fiance, she's my fiance, but then now we're going to be co-fellows because we ended up matching at the same fellowship. So pretty incredible. So you can go to the next one. We were so blessed for that, to be able to spend time together even after that year. This is us now, Johns Hopkins Wilmer in fellowship, and me with her, our other co-fellow. And this is, some people really important. Bert John, he's the head of the cornea division there at Wilmer. He's still my good friend, mentor. We work on a lot of projects together, one of which I'll mention at the end of this talk. And then there's Craig Scott Bauer, who taught me LASIK. And a lot of other people not pictured here: Pascal Loretta, Christina Prescott, Essen Akpak, Ellen Agrari, Yassine Daoud. So many people that had such an impact on me. But what a great year. And here on the left, this is, so right before fellowship, around the same time, I got a job interview, Center for Sight, which is my current practice. And it was just a crazy few weeks, but we came down here, we saw this sunset over the Gulf of Mexico, and we said, yeah, we could move here. This could work. So that's kind of how that idea came about. So next slide.
Okay. All right.
So what we decided to do is after fellowship is we kind of delayed the start of our jobs here on the west coast of Florida. And by the way, Priya here, you may recognize her because she was a Rising Star season 2. So I'm just following in her footsteps, and I'm fine with that. So here's a photo of Spain. So we decided to go back to our roots, and my ancestor, my family is from Spain originally. So we did Caminito del Rey. This is a hike right by Malaga, right north of Malaga, which is a beach area. And we went to Ronda, which is probably the most romantic, beautiful town. One of the white villages with the white houses in Spain. Excellent food. Barcelona. We also went to Ibiza, Madrid, Cadiz, Sevilla. It was amazing. And then in the next slide, we decided to go to Priya's roots. She's from India. Well, her family's from India, and her family's from Kerala. So I thought I had a decently sized family until I met family. And down here, this is just her mom's side. So these are just her mom's brothers and sisters, and then all their kids. So they were really welcoming people, really nice, just made me feel at home. It was pretty amazing. And this is Priya there. And we also took a tour of northern India, Jaipur, New Delhi. And here's Taj Mahal, of course. So nice way to kind of leap into real practice right beforehand. And during this time, there was also something out. Priya was pregnant. There you go. You gave it away. It's there.
Sorry. I was excited.
So right there at that, I remember we were at the Oberoi Hotel, and it was like New Delhi one, I think, or maybe it was the one in Taj Mahal. But so we got she was 20 weeks pregnant, and we found it was a girl. We celebrated. That was little Isabella. And then, before you knew it, little Leo was born, right? So we're starting practice, new kid, new house, little Leo. And this is just hanging out with the family, things you do in Florida, right? Like golf, fish, this is a pond right outside our house, go to the beach, fun stuff. Good place to have a family. Next one. And then I like to talk about my family at work because these people are really amazing. So on the left is my clinic, my clinic technicians, my clinic staff, and we work really closely together. They help me so much. They've really elevated my practice incredibly in a short period of time. And now they're having children too, and it's amazing. So I'm just really blessed to have them. And this is at our Christmas party that we had about 2 months ago. And then here in the center is the ASC staff. So some of them, this is only like a third or a fourth of them, but they're, if you talk about professionalism, efficiency, compassionate care, they're the epitome of it. It's pretty amazing, to fall into a situation where you're working with people of such quality. And again, I feel really lucky about that. So, and that's me operating there. So yeah, back to my family at home. This is kind of where we stand right now. And we have little Leo ready to feast, and we have Isabella taking my hats and wearing them. So things are pretty good, I guess. And we feel very, very lucky.
Yes, beautiful family. Thank you for sharing your journey and creating a personal touch to this episode. So thank you again. And now I will stop sharing my screen so you can take over and present.
Well, I appreciate it. Let's see if I can do this. All right, share screen.
Harder than it looks.
Share. Okay. And then here we go. All right. So the title of my talk here is Maintaining a Refractive Mindset in Corneal and Cataract Surgeries. I think this is important because oftentimes these different disciplines are looked at very different discipline. And in my first 3 years of practice, I've been trying to put these things together. And I've been in a situation where I've had the opportunity to do that. Doing the LASIK enhancements for the practice, also doing cornea, and also doing the cataract surgery. Kind of, how does it all go together? And I always think about all these worlds together. So these are some relevant disclosures. My outline is going to consist of talking about what I consider my toolbox when I approach cases. And I'm going to mention a few cases that kind of outline some of these cases. It's not even necessarily what I would have done now, but it's things that taught me something, and eventually to get to some conclusions at the end about how I deal with these situations. And then the last part is, how to use technology now currently available and also future technology, one of the projects I'm working on, to elevate our refractive outcome. So the toolbox I consider when I think about what are the things I can do to get this person planar or get this person glasses independent is we talk about excellent biometry and corneal diagnostics, right? So corneal diagnostics includes things such as shine fluke imaging or OCT or even corneal biomechanics. Talk about using all the modern IOL formulas and the IOLs, being up to date with that, and updating and optimizing your ACONs, our algorithms. That's all the pre-surgical stuff we can do, right? And I also think about post-surgically, how do we elevate outcomes? And we can do that by offering secondary refractive surgery. A lot of our packages offer that. So we can give them LASIK or PRK if we hadn't hit the target. You can do ICL or piggyback lenses or even corneal ring segments. Depending on the pathology, there are a lot of things you can do after the fact as well. And we want to talk about an adjustable intraocular lens that you all know of, the adjustable lens, which has been awesome because you can change things after surgery, right? And then always kind of looping back with the optimizing our algorithms is getting that data, taking that data and being able to feed it back into some sort of algorithm to optimize your outcome, and always looking at your outcomes, right? So those are my tools. And I'm going to start with a case presentation here. So here's the first case. 72-year-old female referred by an optometrist for worsening vision and glare. She wants to be glasses free for her cataract surgery. You'll see from this picture here, pulling on her eyelid, I see that it's pretty floppy. I'm also seeing a lot of staining, and there's really diffuse kind of staining in her cornea, but a lot of it, there's kind of a band of inferior staining, and it's definitely worse on one side. So we have like an asymmetry, and I see this a lot. So you probably all know what I'm talking about already, but what I'm seeing here with the exam is the patient's vision. She wants to be glasses free. She's vision and glare. She's 20/80 best corrected in the left, 20/30 in the right, but the left eye, she only has like a 1NS cataract, right? Kind of weird. So if we look further, we saw what the cornea looks like. May even be some BMD there. It's hard to see with all the staining, but I'm thinking this may be related. So, Dr. Amescua, and for you, what would you recommend we do next for this patient prior to any surgical intervention?
For a patient like this, I mean, if this is the first time you're meeting the patient, I totally agree with not using the slit lamp like you didn't do at the beginning. So just examining the lids to see if there's any exposure, like ophthalmos, things like that. And you wanna see how this patient's sleeping. Is maybe sleeping more on the left side, on the right side, and things like that. You may want to do a trial of patching at night and see. You may want to do a topography, even a placidus disc topography, a quick tomae topography to see how irregular is the anterior surface. And do a good slit lamp exam to see how's the epithelium, how's the anterior stroma in this cornea.
So you're right, 100%. So now he does have a little lag of ophthalmos, probably nocturnal. There is floppy eyelids, there is staining. So how do you treat this?
How did I treat it?
Yeah.
Well, and this, if the lack of ophthalmos is something that it's important, that needs to be addressed with my colleagues from the oculoplastic service. But if it's something that you can improve just by educating the patient and doing some interventions in the lifestyle, and I think that's the next step. I mean, you of course you're going to do lubrication. You're going to look at make sure that there's nothing in the lids and moving line and all that stuff. I think it's also important to get the best potential acuity on these patients. I use a lot. I'm lucky to have an optometrist next to my clinic, which I can do a RGP over refraction to really get an estimate of what the cataract is doing and what the cornea is doing. So that's something I would also do on one of those visits. Yeah.
Some thoughts. The RGP would have told us right away.
Yeah.
So what I decided to do, just like you said, is let's start treating the ocular surface. This patient doesn't even use artificial tears. So a lot of people will jump to artificial tears here, but I think the major issue is the floppy eyelid, the lag of thalamus. So what I do is, ointment at night, have these moisture chamber goggles that work really well. And I even put them on a little bit of a steroid, just to calm the inflammatory component. So that's kind of what I did. Not to mention, we recommend a sleep study. Ask them if they snore.
Yeah, that's
They
very
do.
important.
So we did all that stuff. And look what happened. It's pretty incredible. So just from 1 month of treatment with the aforementioned interventions, we have the best corrected vision now is 20/40 in the left. So it went from 20/80. The right, the uncorrected's better, corrected about the same. But what's interesting now is that once the staining got better, because now it has improved a lot. Now I'm seeing more basement membrane dystrophy. So it's like, was it there all along and it just uncovered? I don't know. That's what I'm seeing. So there's some EBMD. Still think something else to do here. This patient wants to be glasses free, but so here's a Pennicam. The left, more concerned about than the right. So question for Dr. Ambrosio. We have irregular astigmatism noted here in the left eye greater than the right. What do you recommend we do next? And what do you think it's from?
Well, this is a very interesting case and very common case as well. I think you very nicely addressed the slit lamp, and a lot of people jump into the exams and diagnostic technologies without looking at the slit lamp. So I commend you for taking care at the slit lamp examination. One part of the treatment that I would highly encourage you to do in those cases is omega-3 essential fatty acids. I prescribe them for most of my dry eye patients, actually for most of my patients. And the Coogan's dystrophy, which I don't know if it's a dystrophy or a degeneration caused by the anatomical problem of the eyelid, would benefit highly from omega-3 supplementation. One issue that you should address is that if this patient has any form of ectasia, which I don't think is the case, this irregularity is likely related to the ocular surface and the epithelium. So multimodal refractive imaging go from topography, placido disc topography, which I think it's always beneficial. It will be very helpful for your diagnosis, but not fundamental for the diagnosis in the first presentation. And even today, the discrepancy from Scheinflug and topography from placido would be very important for the diagnosis. But looking at the thickness profile, eventually also the backs of the cornea, the back elevation of the cornea, and also the epithelial thickness would be very important for this case. And I would highly educate this patient that it's likely that the patient may need surface ablation procedure as a secondary procedure after cataract surgery so that you can get the optimal treatment. So patient education for the likelihood for a second procedure will be very important for you in this case. But I think you're doing very, very nicely the treatment. But before doing an IOL planning, I would probably do more treatment for the cornea optimization, for the ocular surface optimization before an exam for planning IOL type calculation. And in these cases, I tend to be more conservative for not indicating any type of IOL that like a diffractive or multifocal of any type. Maybe a EDOF could be a potential idea, but likely this patient is not a good candidate for a multifocal IOL.
I would agree with you. They're not a good candidate right now. So one of the things that I see a lot of these patients, and they always want to be, not always, but oftentimes they want to be glasses free. So what I found is very helpful is to do the superficial keratectomy for the cataract surgery. Wait some time and see what happens. And so that's exactly what you recommended that we do. We treat the surface further, and that's what we're going to do. So this is probably the most impressive sort of change. So we talked about the change from ocular surface, but on this patient, we look at it right now, 20/30, 20/40 best corrected, right? We have central basement membrane dystrophy. So when I see that staining, that negative staining in the center of the pupillary zone, that tells me that this has a refractive significance, big time. So here, I will just do a superficial keratectomy in the OR. It takes me 1 minute. You know, you remove the epithelium, you do a burr treatment, and you put them on some steroids, right? The contact lens and some antibiotic. This is what we got. The patient went to 20/25, right? In both eyes. And look at the refraction. They lost a lot of sphere, even still. So pretty incredible. The patient's pretty happy right now. We haven't even done cataract surgery yet, right? And they got him to 20/25. So I see a lot of these patients, and something I've learned. So if we look here at the pennicams, there's a big normalization on the irregular astigmatism. And I'm pretty confident with my biometric values. There's a lot of consistency. So I'm going to offer this patient if they want. And I was going to ask Dr. Schallhorn here. I don't know if she's here yet, but I guess I'll ask anyone who wants to answer. But the goal is excellent range of vision. Is it okay at this point? Patient is okay with night vision dysphotopsias. Is it okay at this point? Try a different type of IOL. What recommendations for IOLs do you have? This can go to Dr.
Well, I think you did, perfect evaluation and assessment, and I think that
how are you? Thank you for joining us.
I also have a low threshold to take these patients to the minor. I don't do it in the OR. I do it in the minor, LASIK center. I will do a polishing with the burr, and usually these patients, heal very nicely. And I do them if the RGP over refraction tells me that these patients are going to see much better after doing this. But you got to be careful because now it looks good. But if you're going to offer a multifocal lens in this patient, you still have the floppy eyelid syndrome. You still have the meibomian gland dysfunction. So you still have 10, 15 years, 20 years of problems. So it's not that it looks great right now. You solve the problem, but you have to maintain great. And that's the problem long-term with this multifocality. And that's why some of these patients are very happy for 6 months. And then, they may not be as happy. So you have to be careful. I think I agree with you. This looks perfect. And if you can keep it like this, I think the patient's going to be really happy.
You're 100% right. And that's why, with patients like this, I tell them there's two issues here. We can deal with the cataract. We can get you where you want to be. But the dry eye ocular surface issue is a lifelong thing. You're going to have to keep up with it, aggressively. And, if they give me that promise, then, we can go forward. But I have had some success after superficial keratectomy, and I've seen these patients out maybe probably about 2 years of follow-up, 3 years of follow-up. But so, as long as they keep up with it, like you said, and I think they can be a good candidate. So I did end up doing a symphony, the dominant eye and a synergy in the non-dominant, which is a kind of a go-to approach I have. And this patient is very educated and really compliant. She's been doing everything. And she's been pretty happy. So her last post-op exam, she was 20/20 J1. And this is a summary of the case. After eyelid and ocular surface treatment and SK, the corneal surface and irregular astigmatism improved sufficiently to implant these lenses. Like you said, though, it could come back. So we have to be on guard. And the backup plan that I have, and it's not to be taken lightly in someone with dry eye, right? But, I always think about, if this doesn't work out well, we can do a PRK with a LASIK touch-up. The nice thing about doing an SK first is that find LASIK works really nicely if you have an SK done first. You can actually do LASIK. Whereas normally I would just do PRK, EBMD. But if you do the SK first, you can actually have really good outcomes with LASIK. Granted, everything else is good, right? So what I've learned is that dry is important to treat, but sometimes it's not the only ocular surface issue. Don't forget the eyelids. Don't forget EBMD. These are repeat offenders. And in case of EBMD and Salzmann nodule degeneration, SK can improve best corrected vision, refractive error, and HOAs, especially if it's in the central pupillary zone. So the SK can be beneficial even prior to PRK or LASIK patients with EBMD. They can normalize the cornea prior to biometry, especially if you're interested in, if you're thinking about refractive cataract surgery. So I know, Dr. Schallhorn, I know you were operating. Thank you so much for joining us. And do you have any other comments about this? Since I'm going to ask you that question.
Yeah, no, I guess I joined when Dr. Amescua was speaking, and I agree with him. Patients that have floppy eyelid dry disease, it is a lifelong thing. And I think they need to have the capacity to be able to continue treating that, to undergo multifocal lens placements. The other thing that's patients with floppy eyelid syndrome oftentimes have undiagnosed sleep apnea. So looking for that as well, and asking them to be evaluated for that as well. And that's one of those conditions that we talk about, that we find in the eyes, but really can go on to save somebody's life, because you can get pulmonary hypertension with sleep apnea. You can get heart failure. It can be a really serious thing. So all those patients with floppy eyelid, actually, I send to a sleep specialist for evaluation.
Yeah. We did too, actually. We had mentioned that before you came on, and patient did have a little bit of sleep apnea.
Great. And treating that actually oftentimes in severe dry eye patients, or not, we call it dry eye, but it's really not dry eye. It's probably, floppy eyelid keratopathy, but can really make that a lot better as well.
Thank you. All right. And the last thing I'll say is that I think that, if you're going to do an SK, it seems like with cornea in general, 3 months is a pretty good number. You wait for refractive stability, but I usually wait at the minimum 3 months, before I do anything on the cornea, after which I can start considering some sort of refractive procedure. So the next case I'm going to talk about is Fuchs dystrophy and mild cataract case. So this is a 66-year-old female. She was referred to me because she has hazy vision. She's okay wearing reading glasses though. So her goal is not to be glasses free per se, but she wants good vision at distance. So what we see here is a patient that's corrected 20/50, 20/30, right? But her cornea, the biggest finding here is she has guttata, she has Fuchs. So I'll explain why I measure this, but it's about a 4.5 millimeter area of guttata in the vertical dimension, 3+ guttata on the right, 2+ on the left. So definitely a little worse on the right. And again, it's like the last patient. The cataracts aren't enough. We can do the RGP, but just from the slit lamp exam, I can tell the cataract is not enough to warrant this level of vision. At least I'm fairly confident. I've been wrong, of course, we've all been wrong, but it doesn't look like it. So this is the specular, which wasn't a good scan, but there's a lot of dropout in the center. And I'm going to start introducing something here that I use very frequently when I'm evaluating Fuchs patients, and that's Scheinflug imaging, but I'm looking at it, in different ways. So when you have these three features, this is featured SV Patel's paper in 2020, Ophthalmology, the group in Mayo Clinic. I find it's been a really important paper in my practice because I think about these things. So the loss of parallel isopachs, and isopac on the thickness map is the same thickness, and they should be parallel to each other. But when you lose that parallelicity, it tells you there's some sort of edema going on in this context, right? Same thing with the displacement of the thinnest point. So the thinnest point is that little circle, and that should be in the center, more or less. And if it's moved to the side, that also tells you there's some central edema. Same thing with the elevation of the back of the cornea. If it's facing towards the AC, that's another indicator. Something that I've used also that was not in the paper, but I used the relative pachymetry map on the holiday report because this highlights relative differences in thickness compared to sort of what it should be in that area for age match controls. So I think this is so much more powerful than just pachymetry because it's really just relative how it should be there. We know that cornea is thinnest in the center, wider. So is there a relative abnormality? And that's what this map shows me. So I'm seeing about a 9% increase in the center from what it should be, right? So question, panelist question for Dr. Amescua. You have visually significant guttata in this patient. Have what I call tomographic edema. It's not visible at the slit lamp, but I see it tomography. Guttata, edema, and mild cataracts. What do you recommend we do next? Patient's okay wearing reading glasses.
Interesting case, and I think there are many options you could do. Can you remind me the age of the patient?
57. Yeah. 66.
Yeah. All right. So, I mean, there's if the Gutata are pretty much central, you could consider doing a DSO in a patient like this. You could also offer a DMEC and then see, and you can do it as a stage. I've been having some, sometimes you get a refractive surprise if you combine a phaco DMEC. So you may want to do it and then later on do the if I remember correctly, this patient's hyperopic, right? So
Yep.
If you end up aiming, for typical -1, -0.75 with your DMEC, you may end up with a very happy patient, but you may not end up with the refractive outcome that you want. I don't have a lot of experience. I don't have a lot of experience in DSO. I only have a handful of cases. We've been enrolling for the endothelial study, the magnetized endothelial cells of Jeffrey Goldberg. So most of my fuchs have been going that way, and I can't talk about it much, but I think it's exciting. So I think the option is, you want to talk to the patient and see how if you're okay being pretty blurry for a while with the DSO and using a ROCK inhibitor and try to expedite the healing, or you can do a DMEC and a phaco and leave the patient plano, and try to aim for some myopia.
Perfect. I mean, it's almost like you had the slides already. That's exactly what I was going to say. My first instinct, I didn't learn, I learned DSO later and was doing DMAC on patients like this. And that's what I wanted to do initially, but the patient learned about DSO and they really wanted it done. And I thought that, wasn't sure if the edema was too bad for that, but I decided to do DSO and staging it. So the idea being that maybe we'll do cataract surgery later for better refractive outcome. And this is just a picture, just showing a video, I should say, just showing how I do DSO. And I like it because in cases like you said, in central guttata, it's just so easy to do. You can combine it with cataract surgery. Downsides, obviously, the patient has to wait for their vision to come in, and sometimes it'll fail, probably 10% of the time, maybe a little less. But if you pick the right patients with the central guttata and you make this metarrhexis just 4 millimeters, and you don't get into the stroma, so you allow the endothelial cells to migrate in, and you use a Rho kinase inhibitor, you're out. You can have a really good success. And that's when I started doing it like this. This is 4 millimeter diameter here, and I've just had really good success with it in certain patients. And that's what this whole discussion is going to be about. When do you do this versus DMAC versus that? So this patient, I kind of forced my hand and I did DSO, but it was good. And a lot of these cases, it's just things that I did almost like I went to my first choice, but then I learned something from it. So this patient now post-op month 3, 2025. We haven't even touched the cataract, right? And interesting, had about a plus 0.75 hyperopic shift. Something I see somewhere between plus 0.5, plus 0.75, very, very commonly. So we didn't touch the cataract. So what's interesting about this patient is, we'll go forward here with the left eye, but let's talk. So look at the right eye now. Look at the penicam. So 3 months after DSO, it's better. The isopachs are more parallel now. The thinnest point is in the center. There's more parallel isopachs in the center. There's less inferior depression, right? There's a little bit here on the side. And if you look at the relative pachymetry map, it was a plus 8.9%. Now it's a negative 1.9. There is a little area here nasally, as it looks like a little tiny piece of edema, but that wasn't visually significant. And that does tend to sort of go away with time. But yes, because we're only doing a 4 millimeter desmetorrhexis. The thinnest point has gone down. So pretty cool. But here's the thing: she doesn't want to do anything more with her right eye. She just said, "Well, let's get to the cataract. I want to do the left eye first." And not usually what I would do, but I said, "Okay, let's do it." So this is her left eye, right? So her right eye's done here, and she's still very hyperopic there, but she's happy. And the left eye. Thing. So she's got a 4.5 millimeter area of 2 plus guttata. Before I rated it as 3. So I'm saying that this left eye is slightly less guttata. So for what that's worth, we'll see. So here is the tomography, and it does seem a little bit less severe because the isopachs, they're parallel, they're more parallel. And the displacement is not as bad, but there's still definitely some tomographic edema. There's some elevation in the back, and there's a little bit of relative pachymetry rise. So there's some, but less. So the question becomes, can we just get away with cataract surgery here? Is it possible? And the patient wanted to try it. Want to try to get away with cataract surgery, and then we were going to do the cataract surgery in the other eye right after, right? So I decided to try it. So we did the cataract surgery. And what did she say? My left eye did not turn out as good as my right. Right eye hasn't even had cataract surgery yet. She's like a +5 hyperope. But she says, my left eye did not turn as good as my right. This is only 1 month out. Okay, so 1 month out, she's 20/40, that's corrected, and she has 1+ folds in that area. So it's only 1 month out. She's not happy. I've got ourselves in a pickle now. So Dr. Schallhorn, continue to see Decimase folds 1 month after cataract surgery. And this patient we knew had fugues. What do you recommend we do next?
I think you got to talk to her about a little bit about what she wants to do. There's a few options. Number one, you could continue to wait it out, plus or minus the addition of, a Rho kinase inhibitor, either Notarsadil, or if you could get Repasadil from Japan. Number two, you could say, you've got a great response in your right eye. Let's do a desmetorexis in your left eye, although I'm a little bit concerned about the continued edema and the peripheral endothelial reserve. For her, I would probably be less likely to do that, honestly. But, and then the other option is just going straight to DMEC.
But it worked in the right eye, and that was worse.
If she hadn't had cataract surgery in the right eye when you did that. So her peripheral endothelial reserve was probably still pretty high. So, if she wanted to go, she had a good response in that eye. So if she decided to go down the road with that, you'd have to say, we'll try this. There's a chance that, you may decompensate, you may not clear, and then we'll be talking DMEC.
Yeah.
But
that remains
given
to
that
be
it's only a
seen,
month,
yeah.
you could certainly give her more time.
I agree with you 100%. And that's exactly what I'm going to do. She comes back in 2 days. So I'm probably going to give her more time. We're going to see how she does. That'll be a few months. That'll be 3 months. Then I'll see her in a few days. And then, if it's resolved at that point, then we'll see how she does. Maybe we'll move over to the right and finish that up. If there's still default at this point, that's where we're going to talk about some sort of intervention for that. Perfect. All right, so another Fuchs patient. So this is a 74-year-old oral surgeon. So I had to get my wisdom teeth taken out at the beginning of 2022. And because I had done, one side, but the other side still had the wisdom tooth. So found this guy who was recommended by my dentist. And as he's, as I'm under this anesthesia, he's telling me how he was told he has FUCK-EDIs. That's how he calls it. And I told him I'm actually a corneal specialist. So then why don't you just, once I'm done here, why don't you come down and I'll take a look. Because he was told 10 years ago that he can go blind. If he does a transplant, he'll go blind. And maybe they were talking about a PK, I don't know. But I told him that very few people go blind. So told him to come check it, come check me out. I'll take a look. And he did. So what I'm seeing here is he operated on me, first of all. So he did have loops on, so that helped, I guess. But he's 20/40 in the right eye. He's 20/50 best corrected in the left eye. And the right eye, he's got a 3 millimeter area of 2+ guttata. In the left eye, and this is why I'm going to talk about why I measure the extent. He's got a 6 millimeter area of 3+ guttata with haze. And he's got some real edema because he's got edema visible in the slit lamp. He's got 1+ MCE. So the left eye's clearly worse, but the right eye cataract's worse. So the right eye cataract's worse in the right eye, guttata, and we have real edema in the left eye. What do we do first? Well, he doesn't really, this is his specular. He doesn't really want much of he's very afraid of corneal transplant. So this is Penticam for the right. And what we see here is, if you look very temporal, some loss of that parallelicity, it may be a little bit, but centrally, it actually looks pretty good. There's no loss of parallel isopax. The thinnest zone is in the center. It's reasonable. Here we have the corneal thickness spatial profile from the Bell and Ambrosio. Now, we happen to have someone here maybe involved with this. So Dr. Ambrosio, what are the CTSP and PTI graphs from the Bell and Ambrosio Acacia display, and how can we apply them to Fuchs dystrophy?
Well, thank you for this question. And I think when you nicely mentioned the work from colleagues from the Mayo Clinic, Dr. Patel, and they pointed out 3 signs of subclinical edema, as they say, subclinical edema. Is the loss of isopex, the decentration of the thinnest point towards the nasal or superior side, and also the posterior depression. It's not elevation, it's a depression in the back elevation of the cornea. So if you use these scales, that I like the scales you use, you see blue and blue. You see blue in the thickness map and blue in the elevation in the back. And eventually, if you have more edema, you can see some flattening as well in the front surface in many cases. And I like your Holiday mention on the relative thickness. What is the earliest sign of subclinical edema is still something to be studied in a more prospective study, but with a longitudinal data. Only with cross-sectional data as we have today, it's hard to say which is the first sign of subclinical edema. But there are 2 signs that I was honored to do a commentary for ophthalmology in this paper. And I added 2 signs, which is the horizontalization of the thickness profile. But we have to be careful because in some cases, the thinnest point is very much displaced to the periphery. And then the thickness profile will be just going down very quickly because of the smaller area for the calculations. But if the thinnest point is around the center, like in your case, you see this horizontalization. And this is, in many cases, something that you see first before the other signs, especially the loss of isopex. But another sign that I would urge you to look at is at the Scheinflug imaging. The Scheinflug images themselves, they can tell you how the cornea is. And the second hump, and we described that in 2005, very early in the Pentacam days, much before the Bell and Ambrosio. But this second hump was described in a paper that I collaborate with Dr. Price on one of the first reports of his studies on DMAC for using the Scheinflug imaging. So the second hump sign will be very important for me to see. So it's not a matter of having guttae at the slit lamp and documented in the spectral microscopy, but if you see the Scheinflug imaging, the thicker decimates complex is likely a sign of bad prognosis. So this case probably those are the 2 things I wanted to look at. And you can look at the Scheinflug, of course, with the Pentacam, but with corneal OCTs, this can be very nicely documented as well. And we have some good pictures at the ophthalmology commentary. So the thickness profile we have ART max, which is Ambrosio relational thickness, in which we calculate the thickness profile for each point, and then we have an algorithm for looking at for ectasia, and we have also an algorithm that is ready for calculating for Fuchs for subclinical edema. So we have a relational thickness that can be calculated for mild edema, and I think this is a very good case that such of data can impact on your decision. But like in your first case, I would say I would not treat the left eye with a cataract surgery because patient was happy with her vision and her vision was 20/30. And if you do cataract surgery in such cases without doing transplant, the ROCK inhibitor is mandatory in my opinion, at least today. And it starts with aggressive. Well,
thank you so much. And we'll get to the left eye, we'll talk about right after this. So this is the right eye. And I love what you said about the Scheinflug, the thickness of the Decimase layer. That's something that I haven't looked at before, and it sounds really interesting. So the corneal spatial thickness profile that, part of your printout here that you developed, Yeah, so exactly. It's like the more flattening. So here I'm seeing that there is some flattening, but it's not the worst I've seen. Well, because
Yes.
I'm going to show you the one in the left eye. So anyway, in this patient, I wanted to do something for Fuchs first, but he was very scared of transplant. He said that you can go blind from it. He didn't want to do it. He just said, just try the cataract, doc. Just try it. If you need to do the transplant later, that's fine. And if you need to do a PRK touch-up, that's fine. He literally went through the whole thing with him. So I tried the cataract. And I did just a toric. He just wants good distance vision. So I aimed for about close to negative 0.5, 2.38 with a ZCU, GT. And I got lucky here. So he got 20/15 in the right eye. And he still has 3 millimeter area of 2+ glutada, with a well-centered toric IOL. How long will this last? We'll find out later, but we got lucky. He was a static. Now the left eye, though, is a different beast. I'm trying to explain that to him. So let's talk about the left eye. So this is now the printouts for the left eye. So now it's very obvious. Look at the corneal thickness. I mean, this displacement is all the way out there, right? He has microcystic edema here, so we don't even need the Pentacam, right? But the point is all the way out here, total loss of parallelicity, the posterior depression, right? The relative pachymetry, and now we have a real flattening here of the CTSP. It's like a flat line. So, like exactly like you said, Ambrosio, I would not touch this with cataract surgery. No way, right? But he didn't want to stage it because he's a little impatient. So he just wanted to do it together. That's fine. So, that's what he wanted to do. But the patient does have tomographic changes consistent with K edema in the left eye. Should we address the Fuchs with surgery? Would you do it combined? Otherwise, Dr. Ambrosio, would you do it before the transplant, or would you do it with?
Well, I have to face that I'm in Brazil, in Rio de Janeiro, and here we have a long waiting list for a cornea transplant. So when I see a patient like that, I put them on the waiting list so that they kind of wait without needing the transplant. But a lot of people get angry with me because sometimes 2 years, 3 years later, they still don't need, and they are in the line for the transplant. But if I have the opportunity, I would probably do a combined phaco-DMAC or a PDAC if you have a younger cornea donor for this patient, and that's the best. The PDAC is exactly when you use a younger cornea. It's a nice surgery done by Agrawal.
And I'll just add a little bit over here. I've seen Dr. Ambrosio in his clinic in Brazil. He's just impeccable. The way he thinks on all these cases are. I spent a day or two with him. It's just unimaginable the kind of investigation he does before all these cases. We'll be thinking A and he's thinking Z. I mean, it's just like, wait, we got to rethink our strategy. So thank you for your leadership, sir.
Thank you. You are my friend. Don't take a discount on what you said, please.
I have a feeling that he's 100% telling the truth. So this is the Barrett toric calculator. This is, I'm going to do a cataract surgery with a toric and a DMAC. Let's see what happens. So I'm aiming for negative 0.5. So look at this. He ended up in the left eye, 2400 corrected. Manifest refraction plus 2.5 minus 150 at 90. That gets him to 2015. So we ended up with a +3 hyperopic surprise. That's a lot, so not really doing refractive surgery here when that happens, right? Your DMAC graph looked great. Toric was well centered.
I'm sorry, this refraction is like a month after surgery?
2.5 months after.
2.5 months? Okay.
2.5 months. So yeah, it changed. It can change a little bit. We waited a little longer after that, just to make sure, but it was basically stable at this point.
Yeah.
And what a change, right? So, this is why we'll talk about why I prefer staged a lot of times. But so what do we do now? So first of all, let's take a look. So let's look at the Pentacam, the relative pachymetry. Look at that. It used to be like plus 15%. It's negative 8.6%. The DMAC sucked out the fluid out of this cornea to a degree, such an extreme degree that you led to this huge refractive shift, right? And if you look at the CTSP profile now, it's no longer flat, it's actually going down. So it's like, very, very dramatic change. So now Dr. Schallhorn, there's a +3 hyperopic surprise and residual astigmatism after DMEC and cataract surgery with toric. How can we address this patient's residual refractive error, which we're going to assume is stable?
While we are continuing, Doctor, everybody, we have about 5 odd minutes left because we have crossed our mark. Just the FYI. All right.
So we'll kind of speed it up.
Thank you.
I'll be brief then. So sometimes, the first thing I would look at just to make sure you know exactly how much of refractive error you want to address is to look at the epithelium, because sometimes patients that have had edema before surgery and then have a really successful DMEC can get what I call like the saggy pants effect. As their cornea shrinks down, the epithelium stays the same size, and you can actually get some pretty substantial central flattening just coming from the epithelium. So I'd want to look at that probably with an OCT epithelial thickness map. And if that looks like it's contributing, I'd want to do a superficial keratectomy. After that, you've got 2 tough choices. If he wants a surgical intervention, you're talking either, like hyperopic, although it's not terribly hyperopic PRK, which, doesn't have, is less predictable, or you're talking, an IOL exchange, which is not great in the setting of, of having a DMEC, because you don't want to traumatize that graft. So it's kind of like pick your poison at that stage. The level of hyperopia, assuming that doesn't change, and the cylinder you could treat with PRK, but you'd have to inform him about regression. That's a little bit of a less accurate treatment.
I agree. That's what we went with. So we did PRK with 15 seconds of mitomycin, and guess we got lucky again. So the patient ended up 20/25 in that eye. And what's interesting though is that even though he's 20/25 and correct in the left eye, he feels like his left eye is better than the right. Remember, the right eye, we just did the cataract, we got away with just the cataract. The left eye, so treating this gutata that seems like it's not doing anything, it really improves quality of vision. Because the left eye, even though the refraction's worse, even though they're 20/20 -1 instead of 20/20 or 20/15, they think the vision's better. I thought that was very interesting.
If you do a
All right.
point spread function analysis, you document exactly what you just mentioned for the patient subjective complaint.
Yeah. So it's like Snellen is not the whole idea here. I'm going to actually skip around a little bit here because there's a lot. I'm going to just mention this last case real quick. This is a patient that came to me, dense cataracts, a lot of gutata, wide span of gutata, and has had LASIK. So what did I do? What am I going to do? This is where I'm introducing the light adjustable lens. So this is another tool. The right eye, cornea looks decent. Gutata's span is not much. The left eye, cornea is a little worse. Look at the relative pachymetry. So my plan is going to be light adjustable lens in the right, left eye, light adjustable lens with DMEC at the same time. And I talked to Frank Price about this. He's done a few of these. And as long as you don't get synechiae and you have to do things to prevent that, this is going to be a really awesome way to do it, because you wait 3 months, you do the light or for refractive stability, and you could do the adjustment for DMEC. So I'm going to skip around because we really ran out of time, but there's a few lessons here. I learned that, it's really unpredictable refractive shifts. So you really want to treat the fuchs first. If you want refractive cataract surgery. If it's not refractive cataract surgery, you don't mind wearing glasses, it doesn't really matter. But if you want to treat it first, and DSO or DMEC, after that, you get about 3 to 6 months where you get refractive stability. On average, cell loss in DMEC grafts be pretty low if you use a soft shell phaco technique. This has been documented, so it's okay to do that. You can consider combining LAO and DMEC surgery, and PRK enhancements can be very useful. Residual refractive error. I try to avoid LASIK in patients with fuchs or DMEC. So my surgical criteria, this is what I've sort of gleaned from all this, is that if I have gutata less than 2.5 millimeters and no tomographic edema, I'm just doing cataract surgery. Maybe DSO, but I haven't gotten there yet. This is just sort of what I've been working in my mind. I perform DSO prior to refractive cataract surgery if the gutta is sort of like, I do think it matters to some degree how far it goes, because then you look at the periphery, then it must be okay. So that's kind of, this is not the best, but it's what I've used. and it seems to work out pretty well. So if it's sort of like between 2.5 and 5, I think the DSOs work really well so far. And there's some presence of tomographic edema, so I'll do a DSO. And if the guttae is really much wider or there's frank edema, then I just go for a DMAC. Consider combined LL and DMAC if the patient's had type A personality or has had LASIK, like we saw in that last patient. So we talked about the toolbox of the refractive surgeon with biometry, all these things, secondary refractive surgery and adjustable lens. But what about this last part I'll mention real quick? How to optimize our outcomes. Okay. So if you think about optimizing refractive surgery, the ideal is to have a cloud-based solution. You have a patient, you plan the surgery, they undergo surgery, post-op results are updated into the cloud and the model is updated, and there you go. And you can have subclasses of patients, maybe patients with fugues, right? But the power is in the amount of data. So Veracity does this already. This is the software we use, which is from Zeiss. It already helps us optimize our A constants at least. And you can see here, I'll go between arcuates and torics. I can see what the refractive outcome is. And in the right side here, these are all my cases that have been automatically uploaded from the EMR. All my post-op refractions have been automatically uploaded. And it's a way to check through them, check my post-op analysis. How am I doing? And then most impressively, you can actually go in and see how your A constants could potentially be changing. You can look at your A constants for yourself, and you can look at the global ones for everyone that uses Veracity if you don't have enough patients for that lens. So that's kind of what you do here. And you can even separate it by groups of types of patients as well. So this is like an example with the AABU, what that screen looks like. But the problem with all this stuff is that when you're doing A constant optimization, you have to move the whole graph up and down. If you have short eyes and you're working along, if you want to optimize, that's going to bring the whole curve. These are static formulas. So what we need is a way to adjust the entire formula, different points on the formula, and be able to continually optimize and add variables to the formula. What if you have a patient with Fuchs with prior DMAC undergoing cataract surgery? What if you have a keratoconus patient that's been cross-linked and you're doing topo-guided ablations? How do we develop nomograms for these type of situations? And it has to be from the pooling of multiple user data, a cloud-based solution where we have enough where we can train some very accurate models, right? And that's what I'm working with IOL Calc, the Lattice Super Formula. This is the group that, we're working on a way to sort of, they've done the AI part, but trying to streamline it into a workflow situation. And what we have is a super surface. So it's not that you're adjusting the entire formula. You're adjusting maybe for an axial length of 20 and a K of this, then you're going to want the formula to say this, to pick an IO power higher or lower. And that's only going to be available with a lot of data, where the computer is optimizing the AI algorithm using neural nets, is optimizing it at all these different levels independently. So that's the dream. That's what we're doing with Plus, which is the precision lattice universal super algorithm. You start with any formula, you can start with the Barrett, and it just gets better and better once you feed it post-op data. It uses AI to optimize even the Barrett or the Holiday, whatever you use. You can input posterior Ks, you can add new inputs. You don't have to change the whole formula. It's just more data, and you let the computer sort out what's important and what's not. So
Dr.
that's
Rojas,
really cool.
so sorry. We'll just have to wrap up quickly.
Yeah, that's it. I'm done.
Okay.
So 94% on target with just 140 eyes training set. This is the future. So we talked about all these things, maintaining a refractive mindset, the toolbox, case studies, the ways to make it in sort of a systems-based approach. And the goal of all this is the mindset. When I'm planning and performing corneal and cataract surgery, I'm planning and performing refractive surgery. And why is that? That's what patients seem to want. So thank you for your time. Sorry I was rushed at the end.
Absolutely fabulous. I mean, this presentation is going to go down as probably one of the most viewed ones on our whole series, not just this season. So really impeccable work. It's so unassuming when we began, and where it ended up is just unbelievable. The kind of pearls that were there, not just from the panels, but even from you, Dr. Ross. I mean, this was fabulous. and excellent work that
so
you've been
much.
doing, and the way that you're thinking. The people really need to think that way when we, address any cataract surgery or cornea surgery henceforth. We definitely believe that that is the way to go. And congratulations on all the tips and pearls. You brought about so many intraocular lens technology, investigative tools, whether it be some of the, Dr. Ambrosio's signs and tips and pearls from there. You connected DSO to this, and where we can use it, how we should use it. So there were so many tips and pearls for people to take home. We are really going to have a field day trying to dissect and bisect, parts of this session to kind of put it out there for people to see and view. But congratulations on your work. And Julie and Ambrosio and Guillermo, thank you so much for, being here. It's exceptional. Thank you very, very much.
Thank
Jen,
you, Ashvin.
it is a pleasure to be with you. I'm definitely going to see all of you guys at ASCRS, but for the audience, I definitely want to tell everybody, we are just some housekeeping issues. We're really, first of all, humbled that you've attended this session again, and will attend the reruns on the website. But we also want to tell you that we have our social media handles on Instagram and Facebook, or called as Rising Eye Stars. We also have our YouTube channel, Rising Stars in Ophthalmology. Entire event will be uploaded again on our website. And this will be in 48 hours from now. Thank you, Dompe, for being the sponsor for today, and thank you all the other sponsors for participating in the whole series as a whole. Once again, Happy New Year, and I will see you guys very soon next month.
Thank you.
Thank you for this
Bye-bye.
opportunity.
Thank
you.